Hello, my name is Erin South, and welcome to the FDA Office of Women's Health Scientific Speaker Series. Today's talk is titled Ovarian Cancer, Moving to a Personalized Treatment Approach. Before we begin, I have a few announcements for this activity. All speakers are expected to use generic names. If trade names are used, those of several companies should be used rather than that of a single company. Speakers attest that the content they contribute is supported by the best available knowledge or evidence and are reminded to disclose when products or procedures being discussed are off-label, unlabeled, or not FDA approved, and any limitations on the information that is presented. Our speaker, Dr. Khabele, reports the following relationships: Scientific Advisory Board Member for Ovarian Cancer Research Alliance, Overcome, Frederick National Laboratory Advisory Committee, NCI, Board of Scientific Counselors, National Institute of Environmental Science, and the Reproductive Scientist Development Program. Dr. Khabele has received grant funding from the NIH National Cancer Institute. No off-label drugs will be discussed. The views expressed are those of the speaker and do not necessarily reflect official policy of the US FDA. No official endorsement by the Office of Women's Health or US FDA is intended or should be inferred. All inquiries for information should be directed to me, Erin South. Closed captioning is available by toggling the button at the bottom of your screen. Throughout the presentation, you may type your questions for our speaker into the Q&A pod, and we'll address as many as time allows. And now we'll pull up some quick pre-poll questions. Our first poll question: true or false? Inherited mutations in the BRCA1 and BRCA2 genes can increase the risk of developing ovarian cancer. True or false? Okay, let's pull up our second poll question. True or false? High-grade serous tumors likely begin in the fallopian tube. True or false? Okay, thank you. And we'll pull up our third and final poll question. True or false? Maintenance PARP or PARP inhibitor therapy works equally well in tumors with or without mutations in BRCA1 and 2 genes. True or false? Okay, thank you for participating in our pre-poll. That concludes our pre-poll questions. And now our guest speaker today is Dr. Dineo Khabele, MD. Dr. Khabele is the Mitchell and Elaine Yanow Professor and Chair of the Department of Obstetrics and Gynecology at Washington University School of Medicine in St. Louis. She is a member of the senior leadership of the Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine. Dr. Khabele is a recognized physician scientist with extensive clinical and translational research expertise in gynecologic oncology. She leads a translational ovarian cancer research laboratory funded by the NIH National Cancer Institute that has made seminal contributions in the area of chemotherapy-resistant ovarian cancers that are the least likely to respond to any known therapy. Her current research focuses on developing epigenetic targets for therapy and targeting macrophages in the tumor microenvironment. Dr. Khabele has also pioneered clinical training and research programs at multiple academic medical centers. She is an associate editor of Gynecologic Oncology and serves on key medical and scientific advisory boards, including the Ovarian Cancer Research Alliance and the Frederick National Laboratory Committee, NCI. Dr. Khabele is a dedicated mentor, sponsor, and advocate for women's health, women's cancers, and health equity. Dr. Khabele obtained undergraduate and medical degrees from Columbia College and Columbia College of Physicians and Surgeons of Columbia University in New York. She completed her residency in obstetrics and gynecology at the New York Presbyterian Hospital, Weill Cornell University Medical Center, followed by a clinical fellowship in gynecologic oncology and postdoctoral research training in cancer biology at Albert Einstein College of Medicine and Montefiore Medical Center. Dr. Khabele is board certified in obstetrics and gynecology and gynecologic oncology. She was a scholar of the Reproductive Scientist Development Program and the Amos Medical Faculty Development Program Scholar, Robert Wood Johnson Foundation. She has received numerous awards and honors, including induction into Alpha Omega Alpha, the American Society of Gynecology and Obstetrics, and the American Society of Clinical Investigation, an honor society for physician scientists. We are thrilled to have her speaking with us today. Please welcome our distinguished guest speaker, Dr. Dineo Khabele.
Thank you so much. Thank you very much for that wonderful and warm introduction. I really appreciate it, and I appreciate the invitation to speak to you today. I'm going to talk about moving to a personalized treatment approach for ovarian cancer. And my disclosures are here. The opinions expressed here are my own. And as I mentioned, no off-label drugs will be discussed, as Erin South mentioned as well. So we're going to talk about a lot of things related to high-grade serous ovarian cancer, which is the most common type of ovarian cancer, and review some of the treatment strategies we have for it, and then also the urgency to improve current treatments. And then I will end by talking about health disparities and health inequities in ovarian cancer as we want to move towards more personalized treatment approaches. So I want to start with the basics. Ovarian cancer arises from the ovaries and the fallopian tubes, I will argue in a moment, that sit deep within the pelvis. These are reproductive organs here where you see the womb or the uterus, the cervix, and the vagina. And all we can see when we perform gynecologic exams are the outer lips, the vulva, the vagina, and the cervix. So the deeper organs of the uterus, ovaries, and fallopian tubes are not visible and are deep within the pelvis. Cervical cancer is the most preventable. We have vaccination against a human papillomavirus, or HPV, that's related to the pathophysiology of cervical cancer. Endometrial cancer is the most common and is soon to become unfortunately the most deadly in the United States, and currently ovarian cancer is the most deadly. We talk about these being below the belt cancers, and one of the reasons is really they're not talked about as much as other cancers above the belt, such as breast cancer or lung cancer. There's a lot of stigma and shame around these cancers. There's less research related to these cancers, less funding, less awareness, and I'm very, very grateful for the opportunity to talk to you all about these cancers today, particularly ovarian cancer. So ovarian cancer does not meet the top 10 in incidence of female cancers in the United States. However, it is one of the top 10 most deadly. It ranks 6th in cancer deaths among women, and more deaths than any other cancer of the female reproductive system. But as I said, endometrial cancer is this year, this is 2024, has just risen to be above ovarian cancer. Lifetime risk of diagnosis is 1 in 87, and lifetime chance of dying is 1 in 130. Ovarian cancer, if we diagnose it at early stage, this is a patient many years ago I took care of, and this is stage 1A mucinous cancer of the ovary. We removed it intact. The patient did not need any additional treatment and did very well. There's a greater than 90% survival if we can diagnose ovarian cancer at early stage. This is another patient who presented similarly with an enlarged abdomen or belly, and her belly was full of ascites, which is the fluid, malignant fluid that's created by these tumor nodules that line the entire lining of the peritoneum or the abdominal cavity. Despite performing optimal cancer debulking surgery, tumor debulking surgery, where we removed all visible tumor, followed by standard of care chemotherapy, the patient succumbed to disease within 2 years of treatment. So the main issue we have just at the very beginning is how can we prevent or detect ovarian cancer early? And unfortunately, there are no reliable screening tools or early detection tools that are approved or that are clinically available. Lots of research going on in the space, but there's nothing that we can really push forward at the moment. So unfortunately, over 60% of patients are diagnosed with widespread metastatic disease. So there's lots of work to be done from a research standpoint to move new ideas to the clinic to change at least this. We don't have a PAP test or early detection tool or prevention tool similar to what we have for cervical cancer, let's say. So high-grade serous ovarian cancer is the most common type of epithelial ovarian cancer. And this is just a picture of the different kind of histologies. There's mucinous, which the histology under the microscope, the cells look very much like the cells that arise from the GI tract. Endometrioid and clear cell cancers, we believe are derived from benign endometriosis or are related to malignant change of endometriosis, which is a benign but very challenging gynecologic disorder that causes pain, infertility, and implants in the peritoneal cavity. And then again, the most common is high-grade serous. And what we think happens is due to a number of events from chronic inflammation and DNA damage, normal cells that line the inner lining of the fallopian tube develop a p53 signature as a molecular alteration in this particular gene, then develop a serous tubal epithelial carcinoma, which is a precursor that's in the tube. And then because the tube is not a very hospitable environment, but the ovary has hormones and all these signaling proteins and growth factors. The ovary is a much more hospitable environment. So any of these cells that have developed pre-malignant cells or malignant cells in the ovary develop. And then because the ovary sits within the peritoneal cavity, these tumor cells can seed almost immediately. So there's almost immediate spread. So you can see that it's very challenging to identify this p53 signature and the stick lesion prior to this later event happening. This is just repeating some of this, but from my own lab. This is a patient who had a high-grade serous fallopian tube cancer, in fact. And what we see from the patient's tumor, this is the fallopian tube cancer, and some of the molecular markers that identify this tumor as a high-grade serous tumor. P53, PAX8, gamma H2AX is a marker of DNA damage. MIB1 is a marker of proliferation or growth of the cells. So you can see these brown staining is the marker, brown staining in the cancer, the precursor, that stick lesion. And if you look very carefully along these epithelium of the normal fallopian tube is starting to develop the signature of these precancers and cancers. And so this image is just to illustrate how this is a huge challenge to identify these microscopic lesions before they occur. And so what we've been able to intervene with over the years is that in high-risk patients who we know have molecular alterations that predispose or genetic syndromes that predispose them to developing these kinds of cancers, that we can intervene. And we actually end up intervening with surgical means in some patients. So in patients who are at high risk from hereditary cancers, for instance, those who inherit BRCA1 and 2 mutations, at high risk for developing these kinds of cancers, we perform a risk-reducing bilateral salpingo oophorectomy, which is just the long word for saying we remove the fallopian tubes and ovaries. We normally perform these procedures through minimally invasive small keyhole incisions on the belly. But I like this picture, this image, because it shows you the relationship between the uterus, the ovary, and the fallopian tube, and that it's really important to be able to remove the entire fallopian tube at the pelvic brim, all the way to the top part of the uterus, and obtain its whole blood supply so that you're not leaving any cancer cells behind. And then once the pathology is taken out, the pathologists perform this specific protocol called CFIM, sectioning and serially examining the fimbriated end. And And it's important because they take these fine sections of the fallopian tube, look under the microscope, and this is an example of an occult cancer that's found in the tube. And so that's why it's really important to have this procedure done properly, where you remove the entire fallopian tube and the blood supply, and that you have a pathologist who knows how to perform this procedure to accurately diagnose a precancer or a cancer that was that you didn't suspect. So one of my colleagues, Dr. Andrea Hageman, who's here at Sightman Cancer Center, and she's an associate professor in gynecologic oncology, is as one of many of us who performs these procedures routinely. And here she's performing the procedure laparoscopically through keyhole incisions in a small camera. Patients go home the same day. And so in our genetics clinics, we are actually diagnosing people who have predisposition to developing ovarian cancer, but don't have ovarian cancer. And we're performing genetic testing and actually trying to cascade this out to families where we can intervene. And we're performing these procedures, of course, when people are done with childbearing, because this is essentially removing their reproductive organs. And there are other interventions to prevent ovarian cancer in these high-risk patients, but that's not a permanent solution. So often we offer oral contraceptives or a medical intervention for them as well. And we work very closely with other physicians who are involved in making sure that we're preventing other types of cancers like breast cancer in these high-risk populations. So let's say we've now diagnosed an ovarian cancer, patient has ovarian cancer. The symptoms are very similar to other types of symptoms a person can develop from any kind of cancer or tumor in the abdomen, and other conditions that are non-cancerous. So abdominal swelling and bloating, trouble with bowel or bladder habits or bladder function, occasionally abnormal bleeding or discharge. But once a person is diagnosed with symptoms, we combine our treatments of that surgery that I described before, a cytoreductive or tumor debulking surgery, combined after which we provide platinum-based chemotherapy. And the platinum-based chemotherapy is standard of care FDA-approved therapy. Sometimes we give a little bit of chemotherapy first and then perform the surgery, or sometimes we're able to perform the surgery first. But the goal of surgery is to remove all visible tumor. Once platinum-based chemotherapy is completed, then in many patients, it's recommended that we follow this by maintenance therapy. And the development of PARP inhibitors that I'll talk about in a moment, 4 of which are FDA approved, has been a game changer in and really has changed our standard of care for many patients. Unfortunately, most patients who have advanced disease eventually develop more symptoms. Eventually, we diagnose more cancer, and many patients undergo multiple other types of chemotherapeutic treatments over time, over the disease course, sometimes undergo additional surgeries. And unfortunately, most patients eventually succumb to disease. So we're really focused from a clinical standpoint, trying to identify those patients where we need to change the chemotherapy sooner than later, and really identifying what we can intervene to prevent recurrence, or to keep the time to the disease coming back, prolong it as long as possible. So patients in which the cancer comes back almost as soon as it was diagnosed, they're considered from a clinical standpoint to have platinum refractory ovarian cancer. Platinum resistant is if they have a period of time in remission of 6 months, and then greater than 6 months, their tumors are considered to be platinum sensitive. Partially sensitive is up to a year of remission, and then very sensitive is after that. And so prolonging this interval for when you have to really undergo additional therapy for recurrence is really a mainstay of treatment and how we monitor this for individual patients. So for the first recurrence, if a patient has platinum sensitive disease, we actually retreat with a chemotherapy drug. And if there's platinum resistant, we don't give platinum back because of the resistant cells. And we give that as a single or double agent. And then bevacizumab is a targeted drug that is FDA approved, targets vascular endothelial growth factor and blocks the abnormal blood supply to the cancer. And so some patients are eligible for that. Maintenance therapy after the initial platinum chemotherapy, we have observed in certain patients has really prolonged that interval. There's long-term progression-free survival, long-term remissions with it, and I'll show you some additional data about overall survival. So when the cancer comes back, I just want to mention this, that again, we want to maximize that disease-free interval without symptoms from the tumor. When it comes back, they have to think about not only the symptoms from the cancer coming back, but toxicities from the treatment. So the goal of treating recurrent disease is really to think about relieving cancer-related symptoms, optimizing quality of life, keeping somebody around as long as possible, but with a quality of life so they can enjoy being around their family and friends, and they're not in the hospital constantly, or they're not in and out of our clinics with blood transfusions or dealing with really severe side effects or toxicities from treatment. And then trying to delay time to symptomatic disease progression. Oftentimes with recurrent treatments, we can achieve an objective response where we can slow tumor growth and spread down. Sometimes we can achieve another remission with our additional treatments in the setting of recurrent disease. But as I explained earlier, the chance for cure is high, unfortunately. And so there's an urgency to really try to find better treatments upfront once a person has a diagnosis of cancer. And as I mentioned in the beginning of my talk, that there are lots of people trying to figure out how we can prevent this from ever occurring in the first place. So I'm going to return to what we know about high-grade serous ovarian cancer and some of the molecular biology and the genetic alterations that not only can sometimes predispose from a hereditary standpoint of developing ovarian cancer, but also what we see, the molecular and genetic alterations within the tumors themselves. And what we see and what we find is that many of these cancers have defects and alterations in an important DNA damage repair pathway, homologous recombination. I'll talk about that in a moment. But about 50% of tumors, high-grade serous ovarian cancers, have defects in this pathway. And the other 50% are able to repair DNA damage a little bit more efficiently through other pathways. So the interesting thing about the homologous recombination pathway is that PARP inhibitors are used to take advantage of the fact that tumors that have defects in homologous recombination are then extra sensitive to treatment with PARP inhibitors. So what do we mean by that? Here is a cartoon of double-strand DNA and just a cartoon of what happens with single-strand breaks. There's a defect in the DNA here, and double-strand breaks. Single-strand breaks are repaired by base excision repair, and these proteins, including PARP1, are involved in repairing that. Homologous recombination is the most efficient pathway to repair double-strand breaks. And you can see the proteins BRCA1, BRCA2, and other proteins in this pathway. Sometimes genetic alterations can cause these proteins not to function well and actually predispose to developing cancers like breast, ovarian, pancreatic, prostate cancer. So the very thing that predisposes the patient to developing a cancer within the tumor itself is something that helps the tumors become more sensitive or responsive to drugs like PARP inhibitors and platinum. So this is another cartoon here showing how this works. If a tumor has defects in BRCA1 and 2, so the protein is not working at all, you treat with a PARP inhibitor, this cancer cell cannot rely on this pathway to repair DNA damage, and this becomes what we call synthetic lethal. So this is very sensitive to this drug, and the cells die. Now, the tumor cell can undergo additional mutations and then develop or revert back to sort of a BRCA function. And then those cancer cells can survive and they're resistant to the PARP inhibitor. The normal cells that have some BRCA function left in a person's body are able to repair double-strand breaks because they have one functioning gene that encodes for these proteins in this homologous recombination pathway. And so normal cells are more likely to survive. Well, this is from a sort of basic science level of what happens, but these drugs ended up being developed from preclinical studies to clinical trials. And this is the landmark, a follow-up of the landmark clinical trial of maintenance PARP inhibitor therapy in patients who are newly diagnosed with ovarian cancer. And what I meant to add here, and that all the patients had BRCA1, 2 mutations, either inherited or just within the tumor. And so after standard of care therapy, they had surgery, they had platinum-based chemotherapy, they were placed on maintenance treatment. And so in the blue is the PARP inhibitor olaparib, and the red is the placebo. And this published last year was a 7-year follow-up that showed clinically meaningful improvement in overall survival. These are patients who had stage 3 and 4 ovarian cancer. So as you can see by these Kaplan-Meier overall survival curves, that this was a substantial difference and substantial improvement in prolonging life for patients with this disease. So this has changed clinical care, and this is one of the PARP inhibitors that's FDA approved. So how can we personalize treatment? How do we know who's going to respond best or not? And this biomarker-directed therapy, personalized therapy, precision medicine, we kind of use these terms interchangeably. You know, I think of personalized biomarker therapy when I think about those original pictures that I showed you of the histology of high-grade serous. This is what this looks like under the microscope, histopathologic features. As a physician, as a gynecologic oncologist, I want to know, you know, does this tumor look any different from the next patient's tumor? And can I use information from this to help me better counsel the patients or better select the therapy that's going to work best for this kind of cancer? And, you know, we've moved light years ahead in trying to figure this out by the introduction of the Human Genome Project way in the 1990s and 2000s to now molecular testing most tumors. That's part of our pathological readout for many cancers. What we know for ovarian cancer is P53, that initial signature that I showed you in those precursor lesions is mutated or lost in about 100% of these high-grade serous tumors. And then about 51% have some sort of deficiency or defect in the homologous recombination pathway and look like or function like BRCA1 or 2 mutated tumors. And those tumors tend to be more sensitive to platinum-based chemotherapy and PARP inhibitors. And then the other about 49% are HR proficient, meaning that they're able to, they don't have any defects in that DNA damage repair pathway that repairs double-strand break. And they don't have mutations, they have wild type status for BRCA1 and 2. And so from a clinical standpoint, and because I'm a stubborn researcher, I'm most interested in figuring out how we can best treat these kinds of tumors, many of which really don't respond as well to our standard of care chemotherapy. And so a lot of work I've done in my lab is to try to figure out some drug combinations and test really rigorously in the preclinical space. Are there drugs that we can combine with standard of care that can actually reprogram these cells, these types of tumors, to function and behave more like these BRCA1 and 2 mutated or HR deficient type tumors, and then improve response or overcome resistance to platinum and PARP inhibitor therapy? So for the past 20 years, I can't believe it's 20 I've been looking at these epigenetic drugs that target histone deacetylases and other post-translational modifiers of genes. So instead of targeting the gene itself, these are proteins that modify gene transcription or replication or repair. And so in the blue is the function of the protein, HDAC, histone deacetylase. It's kind of these post-translational modifiers in broad categories are the writers, readers, and erasers of gene transcription. And then in the blue over here are the epigenetic drugs. Many of these are some of the examples we study in my lab. None of these drugs are FDA approved for the treatment of ovarian cancer, and they are all investigational. So some of the ways these drugs work in block is if we block some of these erasers, then we can actually reduce transcription in some cases or increase transcription of some of the genes that we're interested in. And then in some cases, we can stall replication forks, and that causes DNA damage over time. So several years ago, I was really interested in looking at chemically diverse histone deacetylase inhibitors, and we performed a drug screen of a variety of these drugs. Some of them were clinically available drugs over here, and some of them were chemical tool compounds. And I asked the question, could any of these drugs alone cause DNA damage just by themselves in ovarian cancer cells? And the screen, the readout of the screen was my favorite, where we look at gamma H2AX. I had mentioned it a little bit earlier. This is a protein that gets phosphorylated at specific sites of double-strand DNA breaks. So we're able to, the blue is called DAPI, and that marks the nucleus of the cell. And this green fluorescent protein are specific sites of DNA damage, indicate that there's DNA damage at double-strand breaks. So we're able to count these green fluorescent sites, and we found that if a cell had greater than 5 of these sites that showed DNA damage, that was most likely to be an HDAC inhibitor that could cause cell death eventually. And so in this assay, you can see here's our control, our negative control. There's no DNA damage. Our positive control is SAHA, which is one of the clinically available HDAC inhibitors used to treat hematologic malignancies. BRD7914 is a tool compound, and so that was one of our experiments that looked like this HDAC inhibitor could cause DNA damage, and this was one of the tool compounds that didn't. And so I was super excited many years ago, now over 10 years ago, that we were going to be able to develop this particular tool compound into a preclinical compound and perhaps then test it clinically, but ended up being just a tool compound, and the particular company that made it was not interested in developing it further. As I said, I'm a stubborn researcher, and we continue to study many other HDAC inhibitors over the years. And I'll just show you some data from some of those that we've studied more recently. In this particular study, this is entinostat, which is another HDAC inhibitor. And we've showed that this is a different assay about DNA damage. It's called a COMET assay, and we measure the tail of the nucleus. And we found that if we compare to control, olaparib, as we said, is a PARP inhibitor, can cause DNA damage. Entinostat as the HDAC inhibitor can cause a little bit on its own, but if we combine them, we saw a synergistic effect. And this was in multiple cell lines. And again, this is the gamma H2AX assay in the left over here. Instead of green fluorescence, we used red fluorescent dye. So then we went on to ask, well, why is this DNA damage occurring? And one of the reasons we think it's occurring because we think these HDAC inhibitors are downregulating the homologous recombination gene pathway. So this is a microarray. This allows us to examine multiple genes at the same time. SAHA is one of the HDAC inhibitors we study. always confused with some of our bioinformatics folks because they use green as down and red as up. And so intuitively, I would always put red as down and green as up, but this is what we have. So what you can see here is that in a coordinated fashion, BRCA2, BRCA1, RAD51, many of these genes that are involved in the HR pathway are downregulated in the presence of SAHA. And this is just a Western blot showing that we could confirm this in this particular cell line, that RAD51 and BRCA1 markers and proteins in that HR pathway are downregulated. So if you can't repair DNA efficiently, it can lead to more DNA damage and ultimately cell death. So we have studied a number of other, sorry about that, HDAC inhibitors. This is another example where we're able to prime the cells with the HDAC, or this is a mouse experiment where we prime. First, introduce the HDAC inhibitor compared to control. This is oral. These are all oral gavage experiments, and then we treat either with a vehicle, with the HDAC inhibitor by itself, the PARP inhibitor, or the combination. And what you can just see over here is that the compared to control in olaparib, well, olaparib, there's a little bit of a difference, not that much, little bit of difference with the HDAC inhibitor, but the combination is synergistic. So we saw a decrease not only in tumor volume, but tumor weights with the combination. Then we took these tumors and we performed Western blots, and we showed that we were able to downregulate in a coordinated fashion BRCA1, the HR pathway, and downregulate expression of a protein called cyclin E that's very important in aggressive ovarian cancers, downregulate proliferation, that's PCNA, upregulate apoptosis, cleaved PARP is a sign of cell death, and then gamma H2AX, which is our marker of DNA damage, is synergistically upregulated by the combination of drugs. This other model is actually a mouse model from patient samples. So this model on the left with the tumors that we engrafted on the sides of the mice, sort of a xenograft because we wanted to collect these tumors. This other mouse experiment is where we have created patient-derived xenograft models where tumors from patients are then injected into mice, and we propagate the tumors in mice, and they develop ascites, belly full of that malignant fluid, and peritoneal implants, similar to what we see in human beings. And when we perform the histology, looks like high-grade serous. When we perform the molecular testing for serous, Paxate, P53, and WT1 are recapitulated in this model. And here, this is just a survival experiment with our mouse model where we had cohorts of mice, and we were able to show that the combination, just focus on the green bar here, that mice that were treated with a combination of the PARP inhibitor and the HDAC inhibitor had improved survival. So we've gone on to do a little bit more molecular analysis related to this. We think that the replication fork is stalled or slowed down by the presence of the HDAC inhibitor. This is entinostat compared to control olaparib and the combination. And what we can do is we can measure replication fork progression with a DNA fiber assay. And I'm not going to go into the details of it, but you can just see that the fork progression is relatively normal and with control and olaparib, but once the HDAC inhibitor is included, the fork progression, replication fork is stalled. So we have a working hypothesis of how this works. The olaparib, which is standard maintenance therapy, as I've showed before, causes single-strand breaks. It prevents repair of single-strand breaks. If single-strand breaks in the DNA are not repaired, it leads to double-strand breaks. The other things that the other mechanism PARP inhibitors can do is they can retain or trap PARP1 proteins on DNA, and that causes replication stress and eventually leads to double-strand breaks, and you can't really repair DNA efficiently. We think that by adding the HDAC inhibitor, we're changing gene transcription of recombination genes. We're downregulating those genes, and then we're slowing fork progression, as you can see here. And all of these things combined are preventing efficient DNA repair of these cancer cells. Unrepaired DNA, particularly double-strand breaks, eventually leads to cell death. So this is the basic concept, and we spent many years developing this concept, and ultimately, after a 10-year period of time, we got to the clinical trial. And this was a phase 1/2 clinical trial of olaparib, the PARP inhibitor with entinostat, the HDAC inhibitor, for recurrent, platinum-resistant, homologous recombination repair proficient ovarian cancers. So this is the most high-risk group of patients patient population who had tumors that did not respond well to platinum-based chemotherapy, and also had the molecular profile where the tumors were not going to be able to, the tumors responded to and repair DNA damage easily. So we thought by combining the HDAC inhibitor, we could hopefully improve outcomes. This was a completely investigator-initiated clinical trial. And unfortunately, it was closed early due to poor accrual. So after 10 years of trying to get it to trial, we got it to trial, closed early due to poor accrual, primarily the impact of COVID and staffing. But we are analyzing some of the tumor samples from these patients. And one of the patients was on trial for over a year and tolerated it very well. So we're continuing to study these drugs. We're using established and primary ovarian cancer cell lines, spheroids, and organoids derived from patients. We're looking at platinum and PARP inhibitor combinations with not just HDAC inhibitors, but other drugs. And these are some of the assays that we perform. So that's a whirlwind of how a physician scientist, a surgeon scientist thinks about a cancer like ovarian cancer. And that, these considerations, it takes years and years of work. And then I haven't even talked about the valley of death of a drug development before we even get to you all at the FDA. But it gives you a snapshot of some of the ways we're thinking about this and the type of work that a lab like mine does. So I'm going to pause for a second, and I'm going to shift gears for the last bit of this. We're winding down Black History Month, and I think about this quite often in healthcare. And this is a quote from the Reverend Dr. Martin Luther King Jr. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. We think about ovarian cancer inequities, and we talked about the numbers earlier about 1 in 78 women will be diagnosed. It's much more common a diagnosis among white women. Unfortunately, the outcomes in many instances are worse among Black women. We do know that it doesn't have to be this way. My colleagues and I wrote about this in 2014, 10 years ago, that evidence suggests that equal care leads to equal outcomes for Black women. And this is across the board for many disease conditions. And this is across disease conditions for gynecologic cancers. I haven't changed this slide much since 2017 because the numbers don't look that much different. If you look at 5-year survival across races is in the blue, amongst white women is in the red, and amongst Black women, you don't have to look too far to just see the outcomes are worse. And so at the same breath that I've told you about all these advances with PARP inhibitors and some of the molecular testing we're doing, does everybody have access to this? And once we've tested, we have all these targeted drugs, do people have access to those? And maintenance therapy, you can be on it for years. How do we pay for these very expensive drugs? How do we manage the toxicities, the financial toxicities as well, not just the physical side effects? So if we think about the broad spectrum of ovarian cancer care, risk reduction, I talked to you earlier about the fact that we now can identify families where they're at risk for developing ovarian and breast and other cancers because they perhaps have a BRCA mutation signature that runs in their family. Yes, we can offer risk-reducing surgeries or medications to try to prevent a person who's not affected from developing that. How many people know that there are these particular mutations that do run in families amongst Black women? It was thought many years ago that that BRCA1 and 2 mutations were not common amongst populations of color. We now know there are particular mutations associated with families from West Africa or from the Caribbean that predispose not only to ovarian, but to, you know, triple negative breast cancer. So awareness is key. Diagnosis. Many people receive delayed diagnosis because I told you those symptoms can be associated with a lot of other conditions. So one of the patients that I showed you earlier, this young woman with this large mass, people thought she had fibroids, which is a benign condition very common amongst Black women. She had a year delay in diagnosis, and thankfully we treated her before she had metastatic ovarian cancer. Do we have equal access to treatment? And then survivorship. The whole point of treatment is to keep people around as long as possible and managing their symptoms, and that include palliative care, symptom management during treatment. But then when the treatments no longer work, do we have equitable care for people, particularly at the end of their lives? So where we can intervene is increase genetic testing and interventions to reduce the risk and really raise awareness that this is not particular populations. This is, you know, people don't even realize that ovarian cancer is a condition that affects multiple types of populations. We have more treatment options. We have so many advances in treatment. Just within my lifetime, how many people have access to those? And people diagnosed with ovarian cancer are living longer. So what are we doing to help them live their best lives? So this is my advocacy slide. And, you know, we have to educate people. When I was in medical school, we were taught that ovarian cancer is a silent disease. That's not true. Patients diagnosed with it are telling their physicians, their providers, their symptoms, and somehow they get other workup besides a gynecological workup. We certainly need more research funding and more funds for cancer care. As I talked about the financial toxicity, from a physician and provider standpoint, we need to look carefully, take a detailed history, perform appropriate exams and tests if we have a suspicion. Learn about symptoms, and these are the symptoms I've talked about, and learn about family history, and perform cascade genetic testing so we can intervene before cancer develops. But we can't do this if we're not trustworthy, if we don't have therapeutic partnerships and personalized care. And we had an event, a grand rounds this morning. Our speaker quoted W.E.B. Du Bois, and the quote was, I think it was, how does it feel to be a problem? So, you know, as a physician and as a patient, as a Black woman in the healthcare system, I know what it feels like when somebody who's taking care of me, if I'm a patient, makes me feel like I'm a problem, you know, or a patient looks at me and doesn't recognize that I'm her surgeon. I think that it's really important that we focus on the problem, which is ovarian cancer, not the person, and that we can come together in partnership with our medical expertise and knowledge and our lived experiences as physicians and surgeons of what we know ovarian cancer can look like and how we can help people who have that diagnosis. And also listening to the patient and the community. The patient herself, himself, theirselves know they know what's different, what's new to them, listening to them and their lived experience. And together we can solve the problem and trustworthy partnerships to create personalized treatment plans for people diagnosed with ovarian cancer. So I think that that's my last slide, and I'm going to stop sharing now. And I think you have your repeat poll, and then I'm happy to answer any questions.
Thank you, Dr. Khabele, for an excellent presentation. We appreciate the amazing work that you've done on ovarian cancer, and thank you for sharing your insight with us today. So folks in the audience, please type your questions for Dr. Khabele into the Q&A pod. And before we get started with our Q&A, we'll now bring up a quick post poll. And as a reminder, this webinar recording will be posted on our OWH webpage, and the link will be shared with all the registered attendees in the coming weeks. So our first post poll question, true or false? Inherited mutations in BRCA1 and 2 genes can increase the risk of developing ovarian cancer. Okay, we'll give everyone just a couple more seconds to respond. And we'll bring up. Okay, so very well. True is correct. Bringing up our second poll question, true or false? High-grade serous tumors likely begin in the fallopian tube. True or false? Okay, and let's see our responses. Okay, true is also correct. And our third poll question, true or false? Maintenance PARP inhibitor therapy works equally well in tumors with or without mutations in BRCA1 or 2 genes. True or false? Okay, and we'll bring up our responses. And the correct response for that one is false. All right, thank you everyone for participating in our poll. So now we've got some questions coming in for you, Dr. Khabele. The first question, what are the biggest challenges that you're seeing in ovarian cancer research?
I would say the biggest challenge is that these cancers are not one type of cancer. We really do have to start with what the tumor, they look identical under the microscope, but these types of cancer, even high-grade serous ovarian cancers, I showed you that kind of pie chart of different molecular alterations. And so we have to really figure out what those mean so that we can target treatment to the tumor. And we're moving in that direction with the PARP inhibitors working better in tumors that have these BRCA mutations or deficiencies in the HR repair pathway. But we have a long way to go. And to do that, we also need more funding, more research funding so that we can do these experiments.
Thank you. Yes. Our next question, what are initial symptoms and diagnostic tests for ovarian cancer? We know you covered that, but would you like to speak on that a little bit more?
I'll reiterate it. I mean, the problem is these symptoms can be symptoms for so many different things. And so what I talk to people about is if people have persistent abdominal bloating, swelling, unexpected new gastrointestinal, GI, nausea, vomiting, diarrhea, or constipation, that's not just because you ate bad pizza, right? It's like persistent symptoms over weeks, or abnormal vaginal bleeding or discharge. Those are reasons to go to see your provider. And then, if they persist even further after that, then seek gynecologic care, because then we can do some diagnostic tests. There are no screening tests for ovarian cancer, but we can do things like an ultrasound or draw some labs to see if there's any suspicion of ovarian cancer.
Thank you. Can you tell us more about genetic testing for family members? And for example, when should this be performed?
So if a patient is diagnosed with ovarian cancer, epithelial ovarian cancer, part of our standard of care is to offer genetic testing to every single patient who's diagnosed with ovarian cancer. If that patient's test comes back and it shows that there's a hereditary cancer that she has inherited, then we recommend testing for her family. So it usually starts with a patient who has the diagnosis. Now, some people are also tested because they already have a strong family history. So when you're talking to your provider, make sure you're telling your family history and ask your family members. There's so many families who don't talk to each other about what cancers run in their families or medical conditions that run in their families. So I would start with talking to your family first. We usually don't like to test for hereditary cancer syndromes till a person is probably in their early 20s. And so, but that would depend on the type of gene mutation, and that would require counseling to decide when.
Thank you. That's really great information for us to have. Our next question, what is the toxicity of some of these epigenetic drugs? Are there antibody drug conjugates being researched to better localize these drugs to the cancer sites?
That is a fabulous question. They're kind of two separate questions, though. So the epigenetic drugs are very, very well tolerated in many circumstances, especially in leukemias and hematologic malignancies. Unfortunately, for solid tumors like ovarian cancer, it would be unlikely that they would be used by themselves. So the very thing that helps them work better when they're combined with like a PARP inhibitor or platinum, sometimes can increase the toxicity and dual toxicity. So that's what we're testing right now. And that's been a challenge of getting them through. Antibody drug conjugates, I didn't talk about much today at all, but are a very exciting area of research. And certainly that could be something to think about.
Thank you. Could you talk about how environmental effects may impact ovarian cancer?
That's another really, really good question. I mean, we know from epidemiological studies that cancers like ovarian cancer are far more common in industrialized nations, right? And then as you look across the globe, as countries become more and more industrialized, access to some of the same kind of factories or food or, I don't know, vehicle smoke or whatever, you can see that there's a trend that then you start to see an increase in cancers like ovarian cancer globally. So certainly epidemiology hints towards environmental factors. We have not pinpointed specific factors. I know that there were just the talk about baby powder and talc, but that has not ever really been specifically proven. But I think that certainly in industrialized nations, we're exposed to a lot of environmental factors that increase risk.
Thank you. What do you recommend for screening for women? Should they go every year to their OBGYN or every few years to catch the disease early?
Yeah.
This person says they hear differing frequency.
Well, I mean, unfortunately, we don't have any screening at all for this disease, right? We don't have any screening at all. So part of it is having a good relationship with whoever your main provider is, whoever the main person is that you see, hopefully either yearly or every other year, and that you are communicating new symptoms to that person. For gynecologic visits, we like people to be seen on a regular basis because there are other conditions like, testing for screening for cervical cancer, or making sure that you're not having urinary conditions that come with menopause or other symptoms. So when you go for those visits, to really talk about, your family history and any new symptoms you may have. But there's no screening like we have for mammograms or for colorectal screening.
Thank you. I think this might be our last question. Does HRP HGSO have specific surface markers that can be targeted by gene therapy, such as CAR T?
That's an excellent question. Not quite yet. No, not quite yet. That's I'm sure that in the future, similar to the antibody drug conjugate issue, that would be coming. There are markers, other markers not directly related to the HRP or HRD pathway. For instance, a marker called HER2/neu. So that's something that's a common protein that's altered in not only ovarian, but endometrial cancer and breast cancers. And so that kind of protein is something that's being looked at for antibody drug therapy, and also other types of gene therapy.
Thank you. And then I think this is a really great sentiment that we received here. Thank you for being a stubborn researcher. Your contributions to this field are invaluable. So I think we all echo that. Thank you so much.
Thank you. Really appreciate the opportunity. Talk to your families.
Thank you. And yes, thank you, Dr. Khabele. Thank you to our audience for joining us today. Just a reminder to folks that you can follow the FDA Office of Women's Health on social media and our YouTube channel to get more information and resources. And I'd also like to take this opportunity to remind our FDA colleagues that the OWH Intramural Research Program is accepting center-cleared concept proposals from now until April 15th, and details can be found on our SharePoint site. Again, thank you everyone for joining us today. This concludes our presentation. Have a great day.
Bye-bye.
Bye-bye.